Well, thank you so much for joining us today. Today we're here for a webinar. It's a very hands-on webinar. We're going to play a game, play with a simulation model. I'm not sure if it's the first time we're doing this, playing a game with a system dynamics model, but it's fun. You can really learn. The question that we have today is, can you fix the American healthcare system? And Rebecca is going to guide us and give us an overview of the healthcare system. And I hope by the end of this webinar, you learn more about how we can maybe fix the problem of the American healthcare system. As I told you before, you can join us on our posts on Poll Everywhere. You can go to Poll Everywhere, pollife.com/rethinkhealth. There's a link in the chat you can also find and go there and participate in this webinar. Next slide. So just a reminder here for all the members of the society, and for those who are not members of the society, the benefits are, we have a long list of benefits, including the free access to all seminar series such as this one, discount on our conference. Oh, it says 2021, but it's actually 2022 next year. Full access to our scientific journal, the System Dynamics Review, exclusive prices on our bookshop, and of course, you're willing to learn more system dynamics. We have a pool of mentors that can help you learn more system dynamics modeling. And also we do have some networking series planning in the next months. So you can also join us to meet people in the field. And you can already save the date for an upcoming conference next year in Frankfurt. It's going to be from July 18 to 22 in Germany. So I really hope to see you there. You can see some more information on systemdynamics.org/conference. There's some information about the venue and the city. So you can go ahead and save the date. There's an upcoming webinar on Introduction to System Dynamics Modeling from 2 weeks from now. And it's free, so you can invite our friends to learn more about system dynamics and take the first steps in system dynamics modeling. This is a free webinar with Len, and it's sponsored by PowerSim software. That's why this is available for all the community. And I just want to give a shout out to all the society sponsors. It's only through their help that we continue working to expand the system dynamics field. And if you'd like to sponsor the society, you can email me at office@systemdynamics.org. I can definitely start a conversation with you from there. And we have a new program at the society. There's an increasing demand for system dynamics, and people are searching for facilitators and other talent to help them understand and use system dynamics in their companies and their organizations. So if you'd like to make part of this pool of talent, and that we can refer you when other organizations contact us, you can find this form on systemdynamics.org talent registration form. I can put in the chat later, and I'm also sending it via email. So if you'd like to join this talent pool, please do so using the form. And right now, oops, skip a slide. I forgot to put it back. Let me just present this one. I'm going to go ahead and give you 30 seconds to go to Poll Everywhere so you can get used to it. I'm just going to switch. There is a link in the chat, hopefully. Rebecca, by now, let me see the chat here. Yeah, I can see there. And I'm just going to change to other here. You guys can see, activate. Can you guys see this poll there? Is it active? Oh, good. I can see that some people are learning. They're interested in system dynamics. Some teachers, researchers. They want to learn more about the ReThink Health Dynamics model because it's related to my work. So it's great. And a lot of people want to learn more about the health sector. A champion who is interested in the using of the ReThink Health Dynamics model in my community and organization. See, there's a few people. So most people are here for their research or learning more about the healthcare system probably. It's good to see this mixture of audience that we have. I can see you learned, and Rebecca has some polls throughout her presentation and throughout the webinar, so I can see you guys got used to it. And I'm happy to introduce you to Rebecca, which is she's the executive director of the society. And she's going to be not sure. She's going to be guiding us today, and we also have the help of Jack Hummer from Hummer Consulting. So that's all from my side, Rebecca. If you want to take over, it's the ball is in your side. Thank you.
Thank you. Thank you, Fernando, for that. Very pleased to have Jack Homer here with me as well. He is the primary modeler along with Gary Hirsch on this project, and we didn't think he was going to be able to join us, but it seems he has. Unfortunately, he's going to have to leave a little bit early. So if you have questions for him, you can put them in the chat. So I am going to start my presentation now. So today, as Fernando said, we're going to share the ReThink Health Dynamics model. This is a model that's been around in use, much like the Climate Interactive model, for quite some time. And we're going to give you a chance to use it. So we're going to give you an experience very much like what we do at universities or with individuals or with communities. Although I'll give you a little bit of background, knowing that you guys are interested in it from a slightly different perspective, perhaps. So let's see, Fernando went through that. So just to start, the ReThink Health Dynamics model is a model of a regional healthcare system that is intended to bring greater structure, evidence, and creativity to multi-stakeholder strategy design. So it's designed specifically to bring people together in a community who are thinking about strategies for spending their money in that community to improve population health. And it makes it very different from other models that came before it and many other models that exist in the health realm. So that's going to be the focus today, is imagining that you are working to improve a real community. So I'm going to start with a video here that describes it succinctly. One really nice thing about this model is that it is available for free for use by anyone. You know, there are people who have used it and can help, and we hope to build some capacity within the society for people who can use this model. So definitely sign up for that talent pool that Fernando mentioned. And there are materials that make that easier. And one thing that does make it easier is a video that explains it. So I'm going to play that for you all. And Fernando, let me know if there's any issue with the sound. I pressed the button, so it should be good.
The American health system is big, complicated, expensive, and it can be much better than it is. When we think of our health system, most people think of doctors, hospitals, insurance, drugs, patients. But really, anything that affects our health is part of that same system. We all need things like clean air, healthy food, safe neighborhoods, quality education, good jobs. But too many of us don't have these advantages. Behind the scenes, everything has to work well and work together as a system for everyone to be healthy and productive, get the care they need, and keep costs down. The problem is, it doesn't. In fact, many challenges are getting worse. What will it take to change direction? People everywhere are scrambling for solutions. They're trying to expand insurance, deliver better care, cut costs, change payment, and finding ways to create healthier conditions in homes, schools, workplaces, and neighborhoods. Unfortunately, disconnected efforts are rarely strong enough or last long enough to move us where we need to go. And progress in one area can even make things worse somewhere else. We need some help. Good data, a shared set of assumptions, the ability to compare scenarios, and the opportunity to imagine a better future. The ReThink Health Dynamics model is just that, a regional health system in a computer. With the model, you can ask what-if questions and get the results instantly to see how various strategies are likely to unfold. Which approaches, alone or in combination, could do the most to save lives, save money, increase quality, and boost productivity? How long might it take? How much would it cost? What are the pitfalls? And how do we do the most with our resources? With a diverse menu of initiatives and financing options, everyone can test their own ideas and track results across scores of measures. It brings together decades of evidence and experience so we can see for ourselves how the health system is structured, where it's headed, and how it responds to our investments. It can even use local data to represent special features in different regions. When all the right people from the region are engaged, we not only learn from the model, but from each other. Conversations become better informed and more creative when we see and feel the consequences of our choices. Together, we can weigh trade-offs, gauge resistance, and craft a compelling scenario, then work to make it real. The model is not a crystal ball or an exact blueprint. It helps to surface assumptions and examine uncertainties, and it continues to evolve and gets better as new research arrives. It creates a safe setting to tackle tough topics and is a powerful tool for those who are serious about moving their health system in a new direction. A healthier future is within reach, but we can't pursue a different path if we can't see it.
Okay, so that in a nutshell gives you an overview of the focus of this model. So it's not about looking at a particular part of the health system. It's not focused purely on primary care. It takes a very holistic, systemic view of the problem at hand in improving population health. So just to give you a little bit of background on the model, it was a long time in the making, and there were a lot of projects that preceded it, including as far back as 1993. So much like with the Climate Interactive model, there was a lot of work that went into getting to this point where it was in heavy use in communities throughout the United States. So, started with a project to transition to capitation, a micro world. Eventually the CDC took it up with Bobby Milstein at the helm, and there was modeling of the US health economy. There was modeling by the team to look at diabetes and obesity, and there's a PRISM model being used that looks at smoking and other interventions more at a slightly lower level. At some point, many of you might have at the conference experienced the HealthBound model. Between 2008, 2011, the strategy that the team took was to develop a model of policy at the federal level. But they were a little bit frustrated by that and found that they weren't able to get a lot of traction there. And so there was a big shift with this intent to work with grassroots leaders who are trying to transform the health system at the regional level. And so those of you that experience the HealthBound model, this has different interventions that are more able to be controlled by people at the local level. And so that's the primary difference here. It is an award-winning team. Bobby Milstein over here in the left was the leader, formerly at CDC, and then he moved over to the Ripple Foundation and ReThink Health to be able to build this up. Jack Homer was the primary modeler, and he's here with us today. Gary Hirsch was also on the modeling team, and Elliot Fisher at Dartmouth and John Sturman at MIT were very involved in developing the simulation and guiding it along. I was brought in later. I actually met Bobby at a conference, and Jack first doing the HealthBound simulation, and then actually trying to get a meeting with Bobby because I wanted to work on this project. And eventually, about 8 years ago, I was brought in at the point where the model had been used with several organizations, but they wanted to really scale it up and get it used by a much larger number of people. And so my role was interface and figuring out how to facilitate it, and essentially coming up with what you're going to experience today, which is the way we have used it in many different organizations. So we've had 22 deep engagements with this model, using it for various things, developing it over time. There were 10 different cities where the model was customized, including San Diego and Cincinnati and Atlanta and various other places. There were hundreds of strategy labs that were done using the simulation, either those customizations or the standard model that you're going to be using today. Thousands of leaders touched it, and it's used in many universities, including MIT and Dartmouth and many others that you see here. So just to give you a quick overview, I'm happy to answer more questions about this later. We don't normally delve into this when we're working with a community directly. We would get into the model as quickly as possible. but just wanted to give you a feel for some of the ways that it was used. One of the early successes was with Atlanta, Georgia, where they brought 75 stakeholders together in a 5-hour modeling session where Bobby actually used the model up front. It wasn't yet ready to be used by people on their own. And within that 5-hour session, they were able to get those 75 stakeholders to approximately 93% consensus on what they should move forward with. And it enabled them to do something that they hadn't been able to do without the model for a very long time, which is move from the strategy part to action. And they've been since then really moving towards this based on this 5-hour modeling session. It's been used a little bit. It could be used, it's been explored using it like the Climate Interactive simulation in a mock negotiation setting. We haven't used it very much in that way, but there is a possibility there to do something like that with it. It was tested at Central Oregon. We also more recently have used it, kind of stretched it in ways beyond the way that you're going to experience today with, as an example, the Great Lakes Bay region in Michigan, where we explored the intersection between health and the economy and got together with business leaders, CEOs, and others in the region who were really trying to figure out how they could, apply leverage to the economy in order to affect population health. And so we did more causal mapping with them, and then they came up with their proposals for what they would do, and we were able to go through some manipulations and put those proposed plans into the model and see if they made sense and help them make choices between various things. So it can be used for that. We did that again with we did this again more recently with the Methodist Health Ministry in the southern part of Texas, where their strategy team used this system dynamics model, and we took their proposed portfolio and some of the options they were considering, and we worked with transforming those assumptions into assumptions in the model to help them think about where they wanted to invest. And what it led to was them investing much further upstream than they were considering in the past, enabling more funding to come into the project so that they could invest in a lot of things. So this can be used in many ways. You're going to experience just one way here, but it is the foundation for most of the work that's been done with the model. So let's start with the ReThink Health Dynamics model and look a little bit more closely at the challenge that we have. And I apologize, we don't have a huge amount of time here, and I know many of you are not from the United States, but I'm not going to spend a lot of time trying to educate you guys on the ways that our health system work. So you can try to get that from the teams that you'll be working with here. You can ask questions if you want, and I'll do that, but we don't want to get bogged down in explaining some of the vagaries of our own system, which are very different from those in other countries. And as you can see here, that difference, we've plotted here life expectancy at birth relative to health spending per capita. And we see that given our health care spending per capita, over time, we would expect that our life expectancy at birth would be significantly higher than many other countries, which we could reasonably expect to be in line with. But what we see actually happening is that the US has worse outcomes for that additional money. And so there's clearly something going on in our system that is leading to these poor outcomes despite the significant amount of spending that we have going on. So what we're going to do here over the next hour and a half, 45 minutes is use this simulation to try to transform the health system in any town to see if we can improve that performance in an average American town of about 300,000 people, which is the standard that we use in the ReThink Health Dynamics model. You can change those numbers. You can even change the population level all the way to the point of the entire United States. But for today, we're going to be focusing on an average region. And your goal today is going to be to craft an effective strategy to improve performance on 5 dimensions. So what we call the triple aim, which is population health, quality of care, and the cost of care, and then what I call beyond. So taking a look at equity and productivity. Those are the 5 main categories of metrics that you can look at to assess your own performance. And we're going to challenge you to sustain those gains over time. And you're going to have the option to decide what you want to do, how you want to pay for it, how proud you are of that, because some of you might have different priorities than others, just like in the communities that we work with, they have different priorities. And then you're going to be able to iterate and try again and see if you can do better than we are now. So just to give you a little bit of background on healthcare in the US, we typically have a population, most communities have a population that's growing larger and aging rapidly, though this is not universal, and we've had to modify the model for communities where populations are falling. There are entrenched inequities among subgroups. So there are advantaged people and there are disadvantaged people, and their experience within the healthcare system can be very different. This is captured in the model. Insurance coverage has expanded recently, or had expanded due to some changes several years ago, but it is not yet universal. And more recently, we have seen that eroding. So some of that is captured in the model as the baseline. Generally, healthcare quality is mediocre, and we have very limited capacity for primary care. So those who need primary care don't always have access to it. We model in the simulation, there is the recovery from the economic recession in the past, but we're finding that that recession in the past has, when coupled with healthcare costs, has pulled people into debt and unemployment. So very differently from in other countries, individuals pay their own healthcare costs. They may not have insurance. And when something happens to them, they find that they can't pay for it. And it leads to a lot of problems. People are highly vulnerable to risky behaviors, hazardous environments, crime, and poverty. This is leading to, all of this is leading to a mounting burden of chronic disease and lost productivity, as well as significantly rising cost of personal health care. So I see there's a question from Pamela about the model being a black box. So today I'm not going to delve deeply into the model. There is a very large document, and maybe Jack can find it for me while I'm continuing this presentation, which goes into a lot of the details. You can delve into that. It's very well known. The model will allow you to change assumptions and to change trends. So those are visible to you. But today we're not going to allow you to change those. And we often don't. Often we'll work with a team in advance to see if they, either to customize or to make adjustments to various assumptions to make it more believable to them and to make it match their own experience. So, okay. Okay, so a question for you. In 2020, about how much did any town, an average American town of 300,000, spend on healthcare services? Curious what you guys think here. What you think a town of 300,000 spends on healthcare overall in the system? Okay, we got it all over the place. It just so happens, and the reason I have this question is just so you have a feel for what it is. It's about, in 2020, it was about $3 billion, a little under $3 billion spent on healthcare, with that being approximately $10,000 per capita. So we're talking about a lot of money here for even a medium-sized city. So let me go through the initiatives that we have in here. So there are about 25 initiatives. They range from things that reduce the risk for getting sick, things that are related to care, things that are related to capacity, and things that are mostly about reducing costs, as well as some funding choices. So and I would like you to think through this, because my next question is going to be what 5 things you think you could do to best improve the population health in any town. Yes, cost per year, Jean-Jacques. So we have healthier behaviors, which is doing programs that encourage people to exercise, to reduce, to stop smoking, or to eat better, things like that. There are initiatives around reducing violent crime in a community. There are what we call student pathways, which are initiatives related to reducing or to helping students move out of disadvantage by going to college and becoming productive members of society with jobs. So programs related to that. There are, this is a set of initiatives related to reducing environmental hazards, and family pathways is much like student pathways in its initiatives related to moving families out of poverty. So helping them find work so that they become advantaged. Within the care realm, we have efforts to improve the quality of preventive and chronic care. We have self-care, which is things like making sure people go to visit their doctor annually to get their checkup and make sure that they take their medication, rather than stopping it before they completely take it. We have initiatives around improving mental illness care, as well as reducing hospital infections. So those are your choices here. Within capacity, you can increase the efficiency of primary care physicians, which means making it so that they can spend less time with a patient while still providing the same quality. We have the opportunity to recruit more primary care physicians. As I mentioned, there is often a shortage of primary care within the United States, and you can recruit primary care physicians generally, or you can do it for those who are disadvantaged, which we call FQHC, Federally Qualified Health Centers, who support those who are disadvantaged. You can also do things to improve hospital efficiency so that they can get through more patients through their system. Within cost, you can offer pre-visit consultation so that people call up on the phone and they talk to a nurse and or a doctor rather than going in to visit the doctor, to help them understand what they can do without coming in. There's care coordination generally, just making sure that we're not duplicating care for people and that we're being efficient in that, as well as post-discharge care, which is all that care after someone leaves the hospital, to make sure that they don't return, become sick again and return back to the hospital. Medical homes is about giving people a one-stop shop where they can go to figure out the kind of care they need, and it makes sure that they are getting specialist help that they need, but not getting it when they don't. Medical malpractice is reform for legal fights to reduce the legal costs related to healthcare. End of life care is about reducing the cost of the time in hospice towards the end of life. So those are the primary choices that we have in there. We will give you in the community, I'll share in a little bit, we're going to give you about $25 million a year in funding. And you have a couple of other choices that you can make related to the funding. We're not going to let you change this innovation funding, go out and apply for grants in addition to what we're going to grant you. But you're going to have the option to institute programs that push us towards value-based payment, so that rather than being paid per service, doctors will be paid based on the value that they provide in terms of helping people with their health. We have global payments, which is slightly different, which is a capitated payment system, whereby rather than getting paid again per time that you come into you come to visit a doctor, you get paid per patient. So again, it's moving towards trying to provide more value for the care and encouraging people to do the right thing rather than just do more testing. And then finally, we have reinvesting savings in here, which essentially says that if you can do a deal with the insurance company. So we have private insurers, we have Medicare, and we have Medicaid. Medicare in the United States is for those who are for the elderly, and Medicaid is for the disadvantaged. So those are two programs that we have in the United States that are used to provide insurance, but the majority of working advantaged people have private insurance. And so you can do deals with those three different insurance types and get them to agree to take some of the cost savings that occurs from these initiatives and reinvest that back in so that you get more innovation funding. So that's another option that you have. So right now, what I'd like you to do is think for a moment about those choices and let us know. You can do up to 5. If you could come up with a portfolio of 5 things for any town, what would you choose? And this is the same process that we go through with communities. So they come in, there may be 50 to 120 people in a community who are thinking about it for real in their community with either a custom model or the same model that you're using with a few minor adjustments. And they're putting a stake in the ground individually about where they think they should go prior to using the simulation. This is what Atlanta did. Martha, environmental hazards is things like cleaning up Superfund sites, for example, lead abatement programs, various things like that. Fernando, can you put the polling? Thank you. Okay, as you do this, what I would encourage you to do is write down what you chose, because you will want to test it in the model at some point later in the day. Okay, so we're starting to see some emerging consensus. 20%, that 19% there actually means about 100% in poll everywhere language, because you were able to pick 5 things. So we're seeing pretty strong consensus on healthier behaviors. Many of you believe that we should be supporting self-care. There's a fairly strong consensus around pathways to advantage for families. And it looks like environmental hazards is pushing forward, as is coordinating care. So we have this in mind. And again, as I said, write down what you did, because you'll want to test that and see if it works and see if you want to change that. So again, enable healthy behaviors, self-care, care coordination are in the lead right now. Okay, I have a question. What percentage of total healthcare costs, again, remember, it's about $3 billion for us. What percentage of total healthcare costs do you think might be needed to invest in new initiatives to significantly transform future health system performance? How much do you think we will need? Okay, it looks like we've got a large number of you who believe we need 10% or more, maybe even as much as 20%. And I'm not sure how high you guys are thinking above 20%. Some of you think that you can actually do it with 1% or less. But there's quite a bit of divergence on what you think we need here. So I'm sorry to say that we're only going to give you seed funding of 1% of annual healthcare costs. So about $25 million. You're going to have this grant for 5 years for a total of $125 million. That's about $75 per capita per year. So that's what you're going to get. And you're going to have to see what you can do with that. Okay, and this is just another question to get you thinking as we move forward. How long would you be willing to wait for a return on this investment? Okay, so the consensus seems to be 5 years, although some of you are looking for a much quicker return, closer to 3 years. Some of you are willing to wait 10 years. I suspect that's because you're system dynamicists. We often experience less than 3 years. So one of the things that we're trying to do with this model is help people think about the length of their investment horizon. The federal government has a fairly short investment horizon, as do many philanthropies in the United States. And it's a real struggle to get even 5 years, despite the fact that you guys seem quite happy with that. And 10 years is almost unheard of. And so be mindful of that as we go through this. Okay, I just want to give you you're not going to be able to figure out all of these metrics, but there are literally there are more than 200 metrics available to you in the ReThink Health Dynamics model. The idea behind it was to make sure that everyone in the community could find their place in here and find the metric that they cared about. At the highest level too, we were trying to broaden their horizons. We're trying to broaden the horizons of communities. So that they're not just thinking about cost, but they're thinking about the triple aim of health and quality of care, which can be measured in many different ways in the simulator. We do use these top measures as the primary metrics for scoring and for our normal quick assessments, but you do have access to more information. Quality of care, inequity, and productivity. We also have things, different metrics that are of more interest to different people, again, as I said, in the community. So there are things that a doctor might be most interested in, a county commissioner might be most interested in, or business might be more interested in. So again, we're trying here to give everyone their place and let them see how this will influence, how the proposal for a strategy for the community will affect them, so that they can all work together to find something that is mutually agreeable. So another question for you to get you to think about from your own perspective, would you, so even though the model allows you to look at these, the triple aim and beyond, all 5 of these metrics, many people have their own desires personally or from their own work perspective. So which would you personally be using as your guide for selecting a strategy? Okay, so it seems we have a very heavy equity focus in this group. We also have a strong interest in just improving the health of the population. The triple aim, trying to balance healthcare and cost, is moving forward, and we have a few of you who aspire to do it all. So that's interesting, and this is pretty similar to a lot of the communities that we work with. There's definitely an equity focus these days. There's been a strong movement in the U.S. to the triple aim, at least. Oftentimes we don't have the right people in the room to be focusing on productivity. It's hard to get the CEOs in the room. That was one of the special things about working in Michigan, was that we had a bunch of the community leaders there. Okay. So again, your goal here is to figure out what will it take to change the system, and we're going to start to move into that. What I'm going to do is, let me just get out of here. I'm going to show you the simulator. We're going to run your favorite example here, which was healthy behaviors. So in your vote, you chose healthy behaviors, and that is actually often the highest choice amongst the communities that we've dealt with. I would say almost 100% of them pick healthy behaviors as their first choice. So here you can see the simulator. And again, as I said, this is completely free for anyone to use. We built some materials for you to learn to use it. And hopefully this session will help you to use it as well. The support for people to use the simulator is not as great as for Climate Interactive. It was a different strategy that we used here. ReThink Health did most of the engagements with communities. So on the first page, there is the video that I showed you. There's also a 20-minute model mechanics video if you want some help with that in the future, or you want to teach it. So for example, Dartmouth uses this every year in a variety of programs, and they just have their students watch this 20-minute mechanics video, and they give them some exercises that you're going to do today, and that's how they get them started, so that it's a lighter lift. To create a scenario, you just go to the Create Scenario tab, and you select from this list of things that you've already seen here. There is a help button next to each one so that you can read a lot more about it. So here we're talking about promoting healthy behaviors, as I mentioned, to try to stop behaviors that lead to chronic physical illness. So smoking cessation, dietary improvements, more exercise, stopping alcohol and drug abuse, reducing unprotected sex. And what that does is it reduces the onset of chronic physical illness and the likelihood of urgent events, as well as the onset of mental illness that's associated with drug abuse. So this is this is sort of the full definition. It gives you a feel for how it permeates through the system. It even tells you how much it costs. So make sure you're looking at that. And it's a simple matter of just checking the box. So here what we've done is we've added enabling healthy behaviors. Today, we're just going to ask you to keep it at 100%. So this is saying we're going to try to do as much as we possibly can, given the money we have at hand. It doesn't mean that you will actually do 100%. The simulation uses a weighted average cost basis to level those out. So your spending may end up being less than you had hoped. We're going to start it right away. You'll notice that the model is still starting in 2019. We can limit this to certain populations. So we have a few different cuts in populations here. And in some cases, you can limit initiatives to a population, or you can supercharge it. You'll see some things down here. So in this case, we're going to just say we're going to do enabling healthy behaviors for the entire population. Here you can see the amount of money we gave you, which I already described. This is $25 million each year for 5 years. And that's all we're doing. And so you'll want to make sure that you name things in a way that you can remember. So I'm going to call this behaviors. I'm going to save and run this scenario. And you'll be launched over to this tab here where you can compare things. So in this case, we're not yet comparing because we've only done one scenario. So everything is green. It looks really good. You can click here and you can see that we used up 100% of our money. When you start comparing, you'll see that the colors change, and green means better, and yellow means slightly better, and red means worse. And so you can start to compare things here. We also have, and we don't necessarily always use this, but today let's use this. We have a score calculator, and this assumes that you're interested in the triple aim and beyond, so that you're interested in balancing the score across those different top level metrics. here. So in this case, you've got a score of about 43.85. So just to give you something to shoot for, you should be able to get in excess of 300 or maybe 350. So right now we've made a little bit of progress. You can see that we've done a little bit of cost reduction. We've reduced, in this case, you can see what we're measuring here is the average fraction of the population with severe chronic physical illness. So we've reduced that, we've improved the quality of care, and we've reduced inequity, which is measured by the average percentage of total deaths attributable to disadvantage. And we've increased productivity, which is measured by the cumulative value of productivity. So this is your sort of scorecard and where you can see the comparison. There. Okay, so let's, so you can click through to see graphs for these different variables here. So for example, one of the reasons we did this behaviors was to reduce chronic physical illness. And what we can see here is that we did reduce it. So the baseline is the gray line, and we did reduce it a little bit. And it's sustained reduction in chronic physical illness. It looks like it's not ill, although it's swinging back a little bit here. We're seeing that costs per capita have fallen, but they're also reverting to the mean, or reverting back to where we were originally, to the baseline. So let's take a look at what we're doing directly. So when we institute risky behaviors, we expect people to reduce their actual risky behavior. So we can look at that here. What we're seeing here is that in the short term, we reduce the risky behavior, but in the long term, they're starting to go out there and smoke and drink and eat at McDonald's and various other things. And so it's going back in. So you've just spent $125 million and did not get a sustainable reaction here. Does anyone have a thought as to why this might have happened? Why do you think, okay, Jennifer, loss of funds. So exactly that. What happens is that over time, we've spent all that money, but a sustained healthy behaviors initiative, it needs to be maintained. If you stop, if you stop with those anti-smoking ads, people will likely start smoking again. So you need to continue to invest in that on an ongoing basis in order to maintain that change. And so we have some tools here to help you diagnose what's going on. Under the diagnose tab. And so what we see here is that this will give you some clues. And so just be aware that this is here, that funding is one of the greatest challenges in implementing strategies. And what we see here is the total annual program spending. So in the beginning, we spend a lot. Over time, the need goes down, so we're spending a little bit less, but eventually we run out of money completely and therefore cannot invest in that anymore. And so this is the actual desired spending over time. So, as we go down, as the risky behavior goes down, the desired spending goes down. But then as we run out of money, we see people getting sicker. And so the spending starts going up. And essentially the ratio of spending to desired value drops precipitously. And by about 2032, we're no longer spending any money at all. And we see the reversion. And so this is a little technique we use to help people see some of the issues that arise with their particular stuff. So my question for you now is, what could we do to fix this? We call this a pitfall. What is one initiative that we could add in here that would help us to overcome this lack of funding? Can you put in the chat? If anyone has an idea, you can look at the list. Okay, we've got Stephen and Brett and Brita. Okay, so the obvious choice is to reinvest healthcare savings. And so I'm going to add that in. So we still have the healthier behaviors. So the same initiative, we're adding in reinvesting healthcare savings. And we're going to make a deal with the Medicare, Medicaid, and the private insurers, such that if we save costs, and you saw we had some cost savings there, we're going to bring that money back into the system, and we're going to get to invest more of that into healthy behaviors. So that money will get reinvested right back in. We've closed that loop. Okay, so I'm going to call this behaviors with reinvestment. I'm going to save and run that scenario. And now you will see that we have, we have two different things here. You'll see that this is no longer green, our original one, because this new one that we did with the fix is better. We've doubled our cost savings. We've almost doubled our health savings. We've improved on quality of care, substantially improved inequity, and seen additional improvement in productivity. And you can see here that we increased our spending. So we more than doubled our spending by adding in the reinvestment here. So yeah. And so Pamela, yeah. So essentially the model doesn't tell you exactly what you're doing, and it doesn't tell you who's doing it. And so that, but it does, what it does do is act as a very powerful convening mechanism. So you have this really cool model that people want to use. And so they come into the room and they talk to you. And so, and it's the power of the conversations in teams that you guys will experience here today, in which those kinds of things happen. And it's by getting consensus around a means of action that, for example, Atlanta was able to get these people to come together and actually shift money to match the strategy that came out of this. So, you have to dig deeper to decide what to do. And there are many other tools to do that, including, for example, the PRISM model, which helps you with healthy behaviors. And we have some information about that. Yeah, it's a group model building session with a pre-made simulation model. So the idea is to use the evidence. So oftentimes when you do a group model building session, you don't have evidence. So we've already done that. And we're making use of all of that work so that people can have access to the evidence and move more quickly forward. Okay, so you can see this here, and let's just look back at, so in all graphs, you can see all of the graphs. I don't think I went in, well, maybe I was in there before. So within health, let's just look at that risky behaviors over time and see what happens. So whereas before, in our first one, we saw this reversion when we ran out of money. Now we see long-term sustainable results on high-risk behavior because we combined two initiatives together. So for those of you who know the Climate Interactive model, one of the major differences in here is that we do put a cap on spending, and which is a very realistic thing. And so you're very limited in what you do, and you have to be very strategic about how you combine things in order to most effectively use your money. And I think that's one of the really powerful things about this, the way that Jack and the modeling team pulled this together. Okay, so let's pull back to the presentation. And when we post the presentation, there will be some slides that go through what I showed you on the go through on there. So essentially what you guys did is you created this powerful reinforcing loop. Investment in cost savings, which was the healthy behaviors that you guys did led to cost savings, which led to more money to reinvest, which led to more investment. And so by creating that powerful loop, you were able to make dramatically more progress. So, oh, I need to go a little bit further down. What we're going to do now is give you some guided exercises to go through, and we'll do this in universities. We often won't do it when we're working with a community, but we figured that you guys might actually be interested in doing this. So we'll give you some time to do this. And if you find that you finish the exercise and still have a little time in your breakout groups, you can, just explore the model a little bit more. So the exercise we're going to give you is to select one of 3 case studies. One is focus on cost reduction. The second is achieving higher value care. And the third is investing even more upstream than we just did in the example here. So we're actually going to, Fernando is going to put you into breakout rooms with about 3 people in each room. And Fernando, do you know approximately how many rooms that's going to be? I can't see how many people. Oh, it's 52 people.
15 groups.
Okay, so about 14 rooms. So what's 14 divided by 3? So 1 through 5 is going to do exercise number 1. 6 through, let's say 9 is going to do exercise number 2, and 10 through 14 is going to do exercise number 3. You can, of course, do more exercises if you have time, or you can just use free play. So Fernando, can you please put those 3 exercises in the chat while I describe them? You won't know until you're in there what room you have. So please, if you can, download all 3 exercises so that you will have them in your room. And once you get in there, note that again, 1 through 5, we'll be doing number 1, 6 through 9, we'll be doing number 2, and 10 through 14, we'll be doing exercise number 3. Okay, so when you get in there, also write down that your username and password is going to be SDS room 1, 2, 3, whichever room you're in. And the password is going to be ReThink 1. You might want to just take a screenshot of this right now so that you have it when you get into your rooms. And be aware, Fernando, can you put the link to the model in the chat? I don't know if I prepped you with that, but you can also take a screenshot of this as well. I'll leave it up for a second more so you can get your camera out and take a screenshot. Fernando, you might also be able to just take a quick screenshot and put it into the chat for people. Okay, so that they can just download it. And I'll move on when you do that. Okay, great. Oh, thank you, Kyle. Kyle got it. Okay, so I'm not going to go any further. What we're going to do now is get you into those groups. We are, Fernando, once you get into a room, Fernando's going to bring one of you guys back. And I don't know which room it's going to be, Fernando, but 3 or 4 of you are going to be yanked back here. And hopefully you'll be cool with us recording it so that we have a recording which kind of shows the process that people are going through as they work on these exercises.
Let's say group 7 comes back.
Okay, group 7 comes back. Okay, so if you could send people in approximately 3 to 4s.
Yeah, that's 12 groups. We have less people who dropped off right now.
Okay, yep.
Eduardo, Samir, and Stefan, you can just stay here. Oh, they moved back. Jack, I could not choose for you not to have a room, but you
they can choose. They can choose not now.
Accept one.
Yeah, they can choose not now. At least it just popped up for me, so I'm assuming they can do that too. Okay, and I'll put in the chat. You guys can log in here. If you're still here and you want to join your room, I think you have to press a button to say, yes, send me to my room. Ah, Eduardo, that's a problem. You can just do the exercise on your own, Eduardo, if you want. You don't have to join the team. Okay, so who's here? It's Stephen and Vincent. Fernando? Vincent, are you here?
Yeah, we have Stephen here, and we have more people also. George just joined us.
Okay, yeah, whoever joined in can help with that, but if they just joined, they're gonna need some, can you chat with them and let them know what to do?
Yeah, let me see just who are here.
Was Eduardo supposed to stay here, Fernando?
Yeah, Eduardo, you're just supposed to stay here. This is your group. You're just in your breakout room now. So we have more people also. Stephen, you guys can unmute yourselves and just do the exercise. Stephen, Eduardo, Monique, Jean-Jacques also. You're more than invited, Danielle, Samir.
Yeah, so Jack, Fernando, and I are just gonna kind of be doing our own thing. So you guys can share your screen and everything if you want.
Yeah. Let me just join a breakout room. Katya is asking for help. Rebecca or Jack, do you want to move to the room 12 and help them, or Rebecca? Room 12.
I'm happy to move there unless Jack wants to do it.
Fernando, I'm afraid I'm going to have to get going. So.
Okay.
Oh, right.
Okay, yeah, you can send me and then I'll pop back.
Okay.
Sorry about that.
This is
All right, Jack.
No worries, Jack. Thank you.
This is really great. Good seeing you too.
Yep, good to
Bye-bye.
see you, Jack. Thanks.
Are you?
so the,
Yeah.
yeah.
Do you guys get the link that was in the chat? I'm gonna put this again.
So we're doing exercise 2.
Yeah, exercise number 2. And pretend I'm not here. I think Stefan, you, Eduardo. Can you talk now, Eduardo?
I think
You're
so.
muted.
Yeah, I'm gonna.
Okay,
Yeah,
perfect.
yeah, I think so.
So okay. Did you guys take a screenshot? The exercise. I don't have the presentation here.
I downloaded it. Are you saying so? One of us.
Oh yeah, that's true.
share
That's
our
true.
screen?
It's here. I do have. Not this one. This one. Jean-Jacques, are you able to move yourself to your breakout room number 11? You want me to move you? You just want to stick around here? Okay. Were you able to find the exercise, Eduardo? Are you still here?
Yes.
Can I still try? Okay. Are you guys reading? I just pretend I'm not here.
Jean-Jacques said something in chat. So Jacqueline, here you can get access here. And are you in a team?
Yes, in room 8.
8.
Okay,
So you're
this
in
is
room,
the access.
so that's the access, and then you just have to use the username and password. If you're in room 8, that's what it is.
Excellent, thank you.
Yep. Okay.
So which room is this one?
This
Fernando?
is, which one is it, Fernando? 7?
7. So basically, Eduardo, there is the exercises here. I put in the chat. This group is supposed to do the exercise number 2. The links to get access to the model is also in the chat. And you can get access with the login that Rebecca just shared. Hi, Samir. This is group 7. You were in the breakout room number 7, but I just
Yes,
put it
hi.
back because Eduardo and Stefan are also in the group 7, so you're doing the exercise together.
Okay.
It's the
Yeah, thank you so
exercise.
much, but I'm facing intermittent cuts of the internet, so that's why I'm keep starting again from the beginning. So excuse me for that. So I'm in group 7, yes.
Yeah, we can hear you well though.
Yeah, but when it cuts, you can't.
Ling, would you like to join a breakout room?
Hi, yes, I think recently in room 1.
Okay, I'm going to move you to room 1 with Mark, who is alone right now. I
Okay,
don't know.
thank you.
It's a possibility he might have. We'll see. Here's room 1.
All right, thank you.
Lin Hui, did you want to join room 10? Stephen and you guys, Eduardo, I don't know if you want to go into room 7. I think it wasn't a good idea to bring someone back here because it's hard to talk with people jumping in and out.
Yeah, okay, I can go there if you send me there, yes.
Do you want to go there, Stephen?
Back to 7.
Yeah, because I think we're just distracting you probably.
Yep, sure.
Okay, Samir, I'm going to send you back there as well. That way you can talk more easily. Oh, although actually, oh, can I not send you there? It's not letting me. Because you, oh, I think you guys can still press join. You just didn't join. Did you say that you didn't want to join, or is there still a button open for you?
Not for me.
I did get an invite then, but I don't see it now.
Okay, yeah, I don't know if I can move you again if you rejected it. Let me just check something.
So do we go out and then go in the Zoom room?
Yeah, I don't know if I don't think I can move you back in. The only thing I can imagine, let's see. is that I move you to some other room and then you come right back and then I move you in, which would be a little disruptive. So at this point, just feel free to talk and I just ignore everyone else. Becky, if you want to be moved to a room, let me know via chat.
So Eduardo and who else is in 7? I'm sorry.
Samir,
Becky?
Eduardo and Samir, but
Samir.
anyone else here can join you if they want to.
Okay, so I finally got my account activated or into the ReThink Health. I am now in ReThink Health. And is the idea for us to share a screen maybe and go through those initiatives?
Yeah, that'd be great.
Yeah.
Do you want me to, I can see if I can get this up.
Yeah,
Yep.
please. Yeah, I don't have that like very good internet here since I moved.
Okay.
So yeah.
Okay, you see my screen?
Yeah.
Okay. So trying to think. Study strategy. So we're supposed to, so make sure you understand initiatives, improve physical illness care, support self-care, coordinate healthcare, invest healthcare savings, and global payment. So we select some combination of these initiatives for our overall strategy. Do you guys want to, shall we, let's see.
Is there
Sorry.
any budget constraint?
Yeah, sorry, I have this thing popping up. Okay. Nope. I don't know why it's doing this.
What's it doing?
No, that's like another, yeah.
Looks like it. Apologies, folks. I seem to have, I got a Microsoft Office pop-up and then the page, then I clicked the page and went out, closed it by mistake. Let's go to. Folks, I'm going to get back into the model and then share my screen again. Okay, let me try this again. Apologies. Share screen. ReThink Health. Okay, share. Okay, let's see if I can get this so the office doesn't pull up. Okay, so now
Then create
check.
scenario, I think.
There we go. So we click on that. Okay.
No, or here at the left, I think up left. Yeah, okay, I think it's the same. Okay, perfect.
Okay. So these are the, okay, should we, did you want to review any of these? We have question mark. We can click on the question mark, hover over the question mark, improve physical health, illness care. So this would be this one here. And that's the pop-up. So
that's
one,
like the information. Yeah, sorry. I have a
did you
delay, so
wanna-
sorry if I interrupt you, Steven. Sorry.
No, quite all right. Yeah, did you want to look at this one or any of the other ones?
I think that's one we have to use for our scenario. So yeah, we click on that.
Okay. So we'll click on that one. Okay.
Yeah.
And what were some of the other choices?
Support self-care. Yeah.
And so support self-care is under risk, maybe? No.
No, it's there
Under-
behind in care.
Oh, right there.
Yeah,
Yeah.
right there.
There it is. Okay.
Let's
Help
see how
people.
that. Yeah, help people.
By making these selections, do you have any budget control for such items you're picking, or just what you think it's of a priority?
Let's see, it looks like you can determine your level of effort.
Yeah, but I think if I understand well, I think we should put it like in 100%, and they'll have like a algorithm that will make it like balanced. That's why I understood, but I'm not 100% sure. From you.
I see. So if we select support self-care, then the algorithm will weight them the same. Maybe.
Maybe you have to choose the amount per year and how long it
here.
will take.
No, that's
see.
the amount. No, that's the amount per year we have to spend. So it's 25 million. So that's why we are spending 125.
Yeah.
During
Maybe available 25 million. Maybe availability is 25 million, but maybe it's up to you to pick part of it.
Okay.
Okay. What other initiatives? Coordinate healthcare. Coordinate healthcare.
Improve hospital efficiency.
Improve hospital efficiency. This is a pop-up. I don't know if you see it.
Yes.
I'm not so sure about that one myself, but maybe this is coordinate 10,000 per year. Time and cost assumptions takes average 1 year to implement, cost 10,000 per year per PCP per year. I see. Okay, and then this is the coordinate healthcare. Sorry. I'm inclined to support that one at least, but what do you think?
Are we supposed to pick 1 or 2 or 3 or
1?
Only 1.
Oh, only 1. Okay. I see. Okay. And then reinvest healthcare savings and global payment. So those are the remaining 2 choices. What do you guys think? hard to pick only 1, but global payment. This is the explanation for global payment.
Rebecca, what are the changes needed to allow implementing this model on different countries with different budgets, different.
It would be a whole new model. You can't really change this. We're just so different from other places. I mean, you could probably, Jack could probably reuse some of the structures, but it's just so different. Yeah, and I mean, that's probably a better question for Jack. But when we've been asked, ReThink Health decided they didn't want to do it. It's essentially a custom job.
The work is similar to interactive climate interactive.
Yeah, it's very similar. Very similar, slightly different strategies.
The terms are different.
Yeah. So I think I'm going to call people back. Which one are you guys doing? Which number?
2.
And your
2.
initial one was
Are we going with which? Well, I don't know if we decided which one were we going with. Shall we just
was it the first one on the list?
the first one, self-care? Okay.
Okay, Fernanda, can we bring people back?
I'm going to stop sharing.
Can you how do we broadcast a message again?
Okay, yeah, I can do it. I think it broadcasts automatically that it's closing in 60 seconds.
Oh, yeah.
Just as an FYI, Fernando, it's very, well, maybe it's just the way I've got it set up right now. It's very hard as a presenter to have your presentation going and see when people come back in a room.
There is an option if you go to Zoom preferences, you can choose with two screens. That helps.
Okay.
You can do it right now.
I think the problem is for some reason my PowerPoint has decided to take over all my screens. And it never used to do that. So I don't know why it suddenly is doing that.
Hi, we're back.
Hi. Okay, thank you guys. So we'll start. I don't know if you all had time to do this. So case study number 1, hopefully there were a few teams that were working on that. In this case, it was a focus on cost reduction. So these teams decided to focus on coordinating care, which means making sure that there are no duplicative tests and that there are no unnecessary referrals, and just generally trying to reduce medication costs. In addition, they were going to, do the reinvestment of savings that we discovered was so powerful when we did healthy behaviors, but they were still limited to the $125 million. What were the primary benefits of that from someone in that team?
Which is that, team 1?
There were a number of teams that worked on that. So when you do care coordination, what's the primary benefit? What is which of those 5 metrics was affected the most?
Cost goes down.
Cost goes down, right? So that's a cost play, and we saw that it was under the cost set of options. So the cost reduction effort reduces costs. What was the pitfall that you guys experienced?
The increase in the unnecessary tests and all of that.
Right. Okay. So what happened was this, what we call specialist pushback, or there are other names for it, The idea is that if you cut the income of doctors, they react by figuring out how to get more money to continue paying their mortgage. So in a system where you get paid for the number of patients that come through your door, if you go in and you cut the number of patients that come through the door, the system is going to push back and make sure that they continue to make the same amount of income. And so any very heavily cost-cutting initiative like care coordination or medical homes or post-discharge care or pre-visit consults or even healthier behaviors is going to lead to this specialist pushback. What was the fix that you found for it? Did anyone find a fix for it?
The global payment.
Global payment. Okay. Yep. And so a very strong way to do this is to institute the global payment, which is essentially getting rid of that fee for service, so that there is no way for them to increase their income. And so you probably found that that had a huge impact on that. So global payment prevents this specialist pushback, or supply push, as we call it. Okay, so case study number 2, achieving higher value care. And this one, folks added a suite of things related to the quality of care, including physical care, self-care for the disadvantaged only, because it's very expensive to promote self-care for everyone. And then care coordination with an extra little push of updating their policies around how they institute new technologies, so that they're only done if they're proven to provide a return on investment in terms of cost reduction. So that, combined with reinvestment of savings and the global payment that we just heard in the other one, was a way to prevent supply push. So when you, what was the major benefit for that? As we know, it was achieving higher value care. So you see a nice push in the quality of care when you get that. What is the pitfall that happened there? Anyone who did case study number 2?
Our urgent care our non-urgent emergency room went up.
Yep, exactly. So we call that exacerbating bottlenecks. So when you improve quality and access to care, like we did here, you're sending more people there, particularly with more preventive care or more self-care. In our other initiatives, things like medical homes or just pure insurance expansion, if you aren't taking into account the supply, you're going to see that you are going to get people going to the emergency room. And over time, that better preventive and chronic care, the better health lowers costs, the cost of that new preventive care will lower costs. So any efforts to expand care or expand access will reduce the sufficiency of primary care and eventually erode chronic care, reducing health and simultaneously leading to the non-urgent visits, an increase in non-urgent visits, which will increase costs. So what did you guys do to fix this problem, to prevent this pitfall? Did you find anything that worked there? Did anyone have time to identify something? Does anyone have a clue as to what you could do in combination? Okay, Alan, great. Increasing the supply of PCPs. So there are 2 initiatives here that will allow you to do that. I don't know if anyone had a chance to kind of play with those and see which one was better. Sometimes it's both, sometimes it's one or the other, depending on how much money you have available. But you can either redesign the primary care for efficiency so that they can put more people through the system, or you could have a program whereby you can recruit primary care providers. And so either one of those can help. A combination might be better if you have, it all depends on the funding that you have available. Okay. Okay, so case study number 3 was investing more upstream. In this case, they took our original healthy behaviors with the reinvested savings that we added, and then they added one more initiative, the student pathways, which again is programs to help students graduate and get good jobs so that they are no longer disadvantaged. What did you see the benefits here? Was there a team that did this one? Which did it have the most impact on? Did anyone identify what it had impact on? You can answer with voice or you can answer in chat. Okay, so the primary benefit of student pathways and family pathways is actually equity. So it's reducing the burden of disadvantage by lifting people out of poverty and into the advantaged group. So that's the primary benefit. Did anyone get at what the pitfall is? No? Okay. So what we find here is that we again bump into the unsustainability of financing, just like in our initial example of healthy behaviors. So healthy behaviors, we were able to get more funding by doing reinvestment, but in this case, we've already done it. And we added another thing on top that we have to spread our money over. And so upstream things like healthier behaviors, family and student pathways, improvements in mental illness care and self-care, and any combinations of these upstream things are extremely costly, and they quickly blow your budget. And so you need to figure out what to do in order to make more funding available. There are many ways that you can do that. You can go out and beat the street for more grants, of course. You can divert money from other projects, but any thoughts on what one could do in order to generate more funding? So in this case, we had investment upstream, which led to dollars saved. We got some money to reinvest, and we were able to do a little bit more. And we saw these, broad-based improvements in equity, health, and productivity. But how can we get even more money? What could you add? What kind of thing could you add in order to fund all these wonderful upstream things? Any ideas from anyone?
Global funding.
Excuse me, say that again.
Global funding.
I'm missing the first word you're saying.
Global.
Oh, global, yeah. Global payment. Global payment isn't going to provide more money for our programs. It might save some money, but it won't provide more money that we can invest back in programs. But it's a good thought, and it's an important intervention. Value-based payment, same thing. Value-based payment will save money for certain players, but it will not save money for the stakeholder group that is trying to invest upstream for the, which is often the public health folks. That money will go back into the healthcare system or to insurers most likely. And so unless there's a special deal made, and our model doesn't let you make special deals for diversion of value-based payments into programs. Alan, you have a hospital efficiency. That can help. That is definitely in the right direction. So essentially what you're seeing is that what helps is anything that reduces costs. So if before, when you have reinvestment in the system, which we do, we can see it can be a powerful engine, but what you need to do is you need to supercharge it by investing in downstream or things that are cost saving. So hospital efficiency can be cost saving, but the things like care coordination as well. And so the idea is to invest in any of those cost saving things or particularly effective things downstream that you have that will feed back into money to reinvest. So this is just a little bit to give you a taste of some of the feedback loops that are in the system that you need to be cautious of as you put together combinations. What we're going to do now is send you back to your teams, or if you're in a team that doesn't have a lot of people, we can move you around, let us know. Essentially, we're going to let you play around for free for a few minutes. Actually, why don't you just do it individually? Are all you guys logged in? Go in there and see if you can put together a scenario that has no more than 7 items in it that you think would be a nice combination. And when you have found one you like, put a heart in it and send it to us by doing a heart. So if you have the simulation open, log in and find a scenario and put a heart in it.
Rebecca, this is just a clarifying question.
Yeah.
The level of effort, does the level of effort remain at 100%?
Yeah, for right now, you can do it at 100%, but you know, you can fine tune it in some cases if there's something that's very costly. If you wanted to, you could like say move it to 50%, but don't just, fiddle with that, like with numbers. It's either like 100% or I want to do this one 50%. Sometimes delaying things can help when you have funding shortfalls. So usually when we're working on it, people keep it at 100%. You have a couple more minutes to put in a scenario and to mark it with a heart. And the way you mark it with a heart is by opening up this little box on the left.
You're
And-
not sharing, Rebecca.
Oh, am I not sharing my screen? I'm sorry. Have I not been sharing this whole time? Or did I just, hopefully I just stopped.
Yeah.
Okay. So, so the way to heart is to open up this box on the left, and you can see all of your runs, and you can put a heart next to your favorite one. And when you do that, this is another special thing about this simulator is that when you do that, I can then debrief by looking at all of your submissions. So you have a couple more minutes to submit something. And I know you haven't had enough time to really think about it. Normally, we would, have 2 or 3 hours and either not go through the pitfalls, or we would extend a little bit longer. Okay. Great. Okay, here's somebody clicking. I'll give a 1 minute more for people to submit a scenario. Okay, please submit your scenarios with a heart. If you're having trouble with a heart, let me know. Okay, so we have 1, 2, 3, 4, 5, 6 different scenarios that have been submitted, and here I can see all of those. So this is the way it works in real life when we're working with teams. We might have 5 or 6 people at a table, sometimes with someone who knows how. Oftentimes we'll train up people beforehand, like PhD students or people on the organizing team in advance, so that they can help people with the computer so that things can move more quickly, because it's a pretty complex interface. But they, at the end of it, they will have submitted their favorite. And so you may have 10 or 20. We've even had 120 people and like 25 different teams submit their proposals. And what's nice is you can see it here, versus each thing. Fernando, do you remember what the vote here was, like in terms of what the primary categories were of interest? I think equity, actually, it was equity. So for example, right now it's organized according to cost. But if you as a group had decided you were more interested in equity, we could order this by equity. And so it allows conversations around a number of things. First, what you care about. It enables conversations around, how much you want to spend on that and what the return on investment is, because you can see that here. And so you're really getting at what people care about, like how much they're willing to spend for equity. So you see, for example, here that B2, well, let's start down here. So interestingly, here we see the strongest one, room 3. I'm curious about you guys, whether you were focusing on cost or whether you were focusing on something else. Can whoever submitted this one here, the Plus Medical Homes, just speak very quickly about what you did? Yep.
We were focusing on cost, so that's what I began with.
Okay, so you had a cost focus, and we saw that a certain percentage of people were really looking for a cost, had a cost focus. And so what you guys did, you focused on medical home, cost, care coordination, which are very strong ways of reducing costs, global payment, value-based payment, all of that is very reasonable if you're focusing on cost. Again, reinvestment so that you can do a little more of all of that. And you were the most successful of every submission here. You also spent a lot less to get that benefit. And so you have a really strong return on investment in terms of net costs. And so the question for this group is this what you want as a whole, as a community? Or do you want something different? And so here we see, so these guys, Team 13 had a very strong showing on costs and a very strong showing on care. They were among the highest of spenders, and they did that with behaviors and student pathways and physical care and increasing efficiency and care coordination, global payment. So this is solid. It's a solid performance across a wide array of metrics, a little weaker on equity and productivity. High spending, pretty good return on that investment. So this is more than a 200% return on investment on the spending here. Here we see another scenario. This had 6 programs or 7 programs. This one is far more focusing just on behaviors and hospital efficiency and care coordination. Normally we would do more of a debrief and let the teams talk. So I'm speeding this up a little bit. I apologize for that. But just so you can see the kinds of things you can do with this very quickly. So here we're seeing, again, I'm assuming you guys had a very strong cost focus and you did really well on that, a little more mediocre on everything else, but again, you didn't spend very much. So you got a very good, in fact, now these guys still got the best return on investment here with their medical homes program versus you guys. And you can go deeper into why and look deeper. Here we have a very strong showing on quality of care. So this team here, number 12, was that what you were focusing on? What was your focus?
Yeah, we were focusing on the whole population and to reach with the program, the whole population. Okay,
great. And so you focused on the whole population, you got quality of care, you got it relatively cheaply compared to the others. And so that was a solid showing. Here we have a fairly even showing across. The cost is a little bit high. Let's see what was going on here. So this is family pathways, PCP efficiency, coordination, reinvestment in order to take that money you save through coordination, global payment and value-based payment. And so that's a pretty solid performance. It was a little bit costly, probably primarily due to the family pathways, and there probably wasn't quite enough money in order to fund that effort. And so my guess is this was starved a little bit by the fact that this family pathway stuff is very, very powerful, but it's very, very costly. I'd be curious if you guys, poked around and you saw that you had unsustainable financing as a pitfall still showing up there that you needed to try to resolve. So you might need to throw in some additional cost saving things so that you get more money available to make that family pathways really, really work. This one here is tops on all measures except for cost, which it's dramatically lower than these 3 down here, but it's also the most costly. So where we spent, 391 million here over the course of the 25-year period, here we're spending 2.58, and we're actually losing money. So we're not saving as much money in healthcare costs as we're spending, but we are getting very strong productivity gains to boost the economy here. So that's a return that this is actually very high on. So we see here that this group did behaviors, family pathways, self-care, which reduced costs and supported more funding for family pathways, PCP efficiency and coordination, and global payment. And that enabled a lot of of these to be very strong. So quality of care went way up and equity went way down. I'm curious if you guys made any of these specific for the disadvantaged, like self-care for the disadvantaged only.
Oh, I'm not sure that it's for the disadvantaged only. I think it's for all people, right? Self-care.
Okay. Okay, that's
Yeah.
possible. Yeah. So, so you know, a lot of people ask us with this model, well, why can't you just tell us what to do? And the reason we can't tell people what to do is because we don't really know what they want. So some of you thought that you know, cost was the most important thing, and you know, you wanted to do it really for a small amount of money. But here we see, you know, we want to spend a lot of money, and we want to make a really big difference in equity, and that's a very hard function to figure out. So we use these kinds of sessions in order to help the communities think that through. What I'm going to do now is take a look at here. This number here, 8, 3, 12, 2, 13, or 3. We have, I guess, 2 different people working on 3, which let's call this one, this bottom one, medical homes, is going to be 1. Pick the one and keep the number in your mind. This is a little confusing. This one is 1. Pick the one that you prefer. And I'm going to ask you to vote on the one that you think is the one that we should advance based on your preferences in terms of the return that you get on your investment, in terms of the 5 metrics, cost savings and productivity gain. So does everybody have their number in mind? 8, 3, 12, 2, 13, or 3? I'm going to start the presentation again to get that up. Okay, which team, and we have more here, which team would you support from the ones that submitted? Please vote. Can you put the poll information up again, Fernando, just in case?
Yeah, I'm just trying to find it.
And actually what I can do, let's make this so that you guys can see it. Which one would you vote for? 8, 3, 12, 2, 13, or 3?
The link is in the chat. Rebecca, can you activate the poll?
Is it not
Let me
active?
see which, if you had, oh, okay, and I activated.
Oh, thank you. Okay, sorry about it not being activated, guys. Not sure why. Oh, it's probably because I showed it to you guys. All right. Let's see. Are we still, if we're still having trouble, go ahead and put it in the chat. Just put your number in the chat and we'll do our best to
People are saying 8, 12, 8.
Okay, so we've got 8. So someone solidly, a couple people solidly in the equity track. We've got a couple people who prefer 12. Brett, why would you select 12?
I like that the care was really improved and that it was financially it wasn't spending more than it was saving.
Right. Okay. Okay, great. And so these are the kinds of discussions you can have. You obviously can spend a lot more time on the debrief. There would be a lot more time so that people would start to converge on the things they want to include in here. We have here you can see what most of the scenarios used. So we found that global payment and care coordination were used the most across the different teams. PCP efficiency was highly used, behaviors was used as well as value-based payment. Again, when you have 25 teams, these numbers start to be more illuminating in terms of what people are thinking of. So you can start to think about how you're moving to consensus. So those are a couple of the really neat things I think about this simulation that could be considered for other simulations. I'm curious, we usually close, and this may not work either. I'm not sure why these aren't working. Can you find the what do you now believe? Let's see if this will work. What do you now believe are the 5 most critical initiatives for your region over the next several decades? Let me see if I can get this, if this is working. It looks like it's working for me.
Yeah, it just turned on.
Okay, thanks. So what do you now believe? And I know you haven't had as much of an experience as everyone else, so this might be hard. But we usually ask this question, and what we find is that there's a much stronger convergence. Are people able to do it? Ah, good. Okay, it's not that it's not working. Okay, great. Yeah, and so this is what we see. We often see, you know, healthier behaviors continues to be a strong contender, but we see that capture and reinvestment of savings, which is something that most people have not really thought about, becomes a front runner. We often see care coordination popping up as it is here, moved contingent global payments popping up, and we see some other things sort of falling by the wayside. And so this is where you're starting to see a little bit more convergence. And, you know, this was the example where Atlanta, they were just sure of what they wanted to do as their top things. And so they ran with it. And so that's an interesting thing that typically comes out of this. Oh, I shouldn't have done that. So just a couple more things, you know, generally we've got a lot of pitfalls. We saw unsustainable program financing, spreading our resources over too many initiatives, lopsided investments, spending too much downstream or spending too much upstream without combining them together. Combining them together is the most powerful set of initiatives. You have to be mindful that you don't trigger specialist pushback, that you have a plan for that, and that you don't introduce capacity bottlenecks. And just generally, you want to make sure that you're not, pursuing narrow goals or neglecting certain populations or focusing only on short-term impacts. And the model lets you do that. Now, I'll show you, there are a couple papers that Jack wanted me to point out that have been done that can summarize this, and I'll try to put them in the chat for you guys. But just generally, you want to select care and risk initiatives based on cost effectiveness to avoid spreading limited funds too thinly. You want to be balanced. Cost and care initiatives for fast impact on cost, but risk initiatives for broad progress on health cost, equity, and productivity. You want to make sure that the system is well incented with global payment schemes replacing fee for service to ensure provider cooperation with everything that you're doing so that they don't break it. And you want to make sure that you've got some sustainable financing. The ReThink Health has a lot of tools for helping people think more creatively about financing and getting them to move in directions that really support that reinvestment scheme. And again, you want to apply initiatives across the whole population for the strongest benefit. Some things will depend on the place, but we found for the most part, the strategy works in most communities. Here's a nice picture of it. Start with a little bit of funding. Fund your programs first, clinical initiatives and payment reform for quick cost savings. Plow that money back in through reinvesting of savings into those upstream things like healthy behaviors and environments. Plow that additional money back in and really fund that upstream costly pathways to advantage for families and for students. And so this is a really nice way to institute a strategy in a community, and we've got a lot of folks doing that. You can take a look at these two papers. Jack wanted me to alert everyone to this new chapter in a book that is the latest and greatest on the dynamics of the system. And then this is a classic health affairs paper that was done in 2016, where we sort of lay out more details about this theory of system change. That is a very solid one. So that's it. I can stick around and answer more questions if people have them, or I don't know if we really had the Q&A. It was hard to have Q&A active, but I don't know if you had that active. Probably not, Fernando.
No, we didn't have that.
So, or you can like send emails to us and let us know, and we can try to connect you with more information. Fernando will also make sure to get, the slides and other information up on our site so that you can access materials. We're very happy to, if there are folks again, Fernando, can you put in the link to what's it called? The talent pool. So we're also looking, we want to help, the society wants to make these kinds of models more accessible and more known to people in the community, and build capability within the community to use these things that have been well developed and proven to work, so that we can really spread systems thinking and get people excited about the field and create our own engine of growth. So if you're interested in that kind of stuff, let us know. We can develop programs to teach people rethink health, give you an opportunity to learn whatever it is you think is helpful. Just let us know. We're trying to do a bunch of stuff. Do you want to say anything more, Fernando?
Yeah, just a reminder to send us feedback. You just got a link on your email, so if you can send us feedback, it's very important to us. And just a reminder that we have an upcoming free webinar in 2 weeks from now with Len, so you can definitely invite your friends to this introduction to system dynamics modeling. And I really hope to see you in 2 weeks then. That's all from me. Thank you so much for attending.
Thanks, Eduardo. Bye. Or was that did you have a question, Eduardo, or no? I can't hear you. Can you hear him? Oh, Stephen says the talent registration form page is blank.
It's not, it opens for me. It's working for me. Let me just check on the page. I'm just gonna stop recording here.